morning and good afternoon, depending on where you're tuning in from. I'm so happy you can join us here for a very special live Q&A. We're here to answer all of your questions about congenital CMV. My name is Kayla McNally, and I am the Executive Director for the Canadian CMV Foundation. Really thrilled to be hosting today's event. I do want to say a big thank you to our partners at Centricity Research for partnering with us on this activity and for their commitment to advancing research and sharing information about CMV. As you probably know, June is CMV Awareness Month around the world, and this year's global theme is Reduce Your Risk. So we have been sharing information and organizing activities and events all month long to spread the word about CMV and how you can reduce your risk. So I also want to say a big thank you to everyone who has taken part in these activities across the month. So we have a fantastic expert panel lined up today to answer all of your questions about CMV. We have been collecting questions from parents through social media all month long. But if you're watching live right now over on Facebook or YouTube and you have questions that you would like answered, please comment them and we will pull them up and our panel will answer them for you. So without further ado, I'm going to bring them in here. First off, we have Rob Tatro, who is the president and founder of the Canadian CMV Foundation. And among the many hats that he wears, first and foremost, he is a father and the father of a child who was born with congenital CMV. So he knows all about the parent experience. He's been through it all. He's been actively involved in advocacy in his home province of Manitoba, but also all across Canada. So he has a really unique perspective and a lot of great advice to share. So thank you, Rob, for being here.
Thanks for having me, Kayla.
We also have Dr. Fatima Kakar, who is a pediatric infectious diseases specialist at the Centre Hospitalier Sainte-Justine in Montreal. She is also the co-founder of the CIM, the Centre d'Infectiologie Mère-Enfant, which is an incredible clinic that is improving the lives of pregnant women and young mothers, as well as their children who have been affected by viruses like CMV, HIV, and now COVID-19. She is also on CMV Canada's Medical Advisory Board, so we are very grateful to have her on that committee, and we're very grateful to have her here today.
Well, thank you guys for doing this.
Excellent. And then last but certainly not least, we have Dr. Joe Serber here, who is the Chief Medical Officer at Centricity Research. He has over a decade of clinical research experience. He is dual board certified by the American Board of Family Practice, as well as the National Board of Physicians and Surgeons. He is on the faculty of multiple medical schools and has a passion for teaching the future leaders in medicine about research. So a big thank you to Dr. Joe Serber for being here today.
Thanks for inviting me. I'm happy to be here.
And again, I want to say a big thank you to our partners at Centricity Research for their commitment to advancing research in the field of CMV and for supporting the many events that we've done throughout CMV Awareness Month. So I have a number of questions here that have been submitted from families, and I'm going to pull them up. But again, a reminder that if you're watching live, please feel free to share your questions in the comments and we will bring them up. I'm going to get going here. So I'm just going to throw a question out here and we'll see. So is it safe for pregnant women to be close to newborn CMV babies? I don't know if anyone here wants to take that one on.
Sure. I think it's really important that pregnant women be aware that any child could be a CMV baby. And I think that's the most important thing because yes, babies who have CMV will excrete it, but toddlers are excreting CMV all the time. And so it's hard to identify in a crowd of children which one is going to be excreting CMV. So as a general rule, pregnant women can be close to these children, but they have to be careful when it comes to the secretions of these children. So tears and saliva and urine if they're changing diapers. They really have to be very cautious about being in contact with the saliva and the body fluids of toddlers in general. So if they have to be close to a child that they know has CMV, they really have to be cautious about washing their hands after changing that child's diapers and really avoiding the saliva, predominantly facial contact with that child.
I want to echo one of the things that Dr. Kakar said there. In our area, as much as 1 out of 3 children by age 5 are infected with CMV. And that just tells you how important it is to wash your hands because, we're all wiping noses, wiping saliva, holding babies, drying tears, picking up toys, all of that kind of stuff. So hand washing, hand washing, hand washing, hand washing.
The parent side of things, I just want to say, like, parents are going through enough of a tough time. The last thing they need is for friends and family to be, stigmatizing their CMV child because, he's a boogeyman, he or she's a boogeyman because they have CMV, right? So I think it's important to understand that, 1 out of 3 or 1 out of 2 or however many babies have this. More importantly, the prevention piece is the important piece.
Thank you. Now, the next one here, this is one that we hear all the time from almost every new family that we get in touch with. They ask, why wasn't I told about CMV by a healthcare provider during pregnancy? Dr. Serba, I don't know, as a family physician, do you have any insights onto why CMV isn't regularly talked about with pregnant women?
We're making strides in doing so. But in speaking with Dr. Kakar prior to the show, it's interesting that, they know about so many other things that cause congenital problems, but not CMV. So it's an area for improvement for all of us.
Sure. Dr. Kakar, do you have anything to add there?
I think that's it. And I think also what's changed is now we have treatments that are, good and effective, and we've got a lot of interventions. So there's something we can do about it. And there's ways we're looking at even preventing it. So there's more of a momentum now, even than there was 10 years ago, to really get that information out there so that cases are identified, tested, treated. And of course, the best thing would be to prevent them.
And like, parents are willing to do anything. I know my wife, she bought all the books and she was reading all the best practices. And yet, we had never heard of this. Like every other parent that's ever, that you've ever chatted with, Dr. Kakar, these CMV parents, we're all so pissed off about this. So my job here as president and chair of CMV Canada is to fight and advocate for change. So I promise you, anyone who's watching, who's listening, this is on our priority list, and we are working hard to change status quo, to change the guidelines. Now, the guidelines have recently changed. The OBGYN guidelines have recently changed to kind of include it a little bit, but we need to do better and we need to do more awareness. So it's part of our mandate for sure.
Yeah, and we know anecdotally that parents want to know, but we even have the data to back it up. We've done a lot of surveys with pregnant women and with parents, and they all want to be counseled. Like Rob said, they're ready to go, they're primed, they're reading the baby books. So I would just add that if you're a healthcare provider out there, we really encourage you to have these conversations about CMV with your patients. And we have a lot of tools and resources. We have handouts and papers and documents. So please reach out to CMV Canada if you'd like more information.
Now, and just to add on, we had this discussion this morning in clinic, but almost as soon as your child's registered for daycare, in that registration package, you should get a pamphlet about CMV to say, because it's almost automatically, reflexively, because that's where the transmissions are happening to so many of these families. So, the education piece could start right there.
Completely agree. I love that.
Excellent. So Dr. Kakar just mentioned the fact that there are a lot of treatment options available today. One parent asked, what factors should I consider when making the decision to take or not to take antiviral medications to treat my child? Rob, I know this was something that you and Michelle really kind of grappled with when you first got the diagnosis, and it all happened so quickly. What was that thought process like for you? What factors did you consider?
I really feel like it was a different era. It was 14 years ago, but back then, ganciclovir was, not common at all in Canada, at least, and hadn't been used yet. These antiviral treatments hadn't been used yet in Manitoba, so they were suggesting it to us as a symptomatic child. They said, you know what, the studies indicate that there's better outcomes. We suggest you do it. We read the studies, I read the articles, but at the end of the day, I sat down with my infectious disease specialist and I said, what would you do if this was your child? And they said, we would treat Alexandre. So we treated because we have full faith in, our experts. And I think that Dr. Kakar, when you guys are making the recommendations as to whether or not to treat, this isn't a whim of a decision. You guys are factoring in all the symptoms, all of the likelihoods, the health of the baby, all the potential outcomes, and you're making a recommendation. So I would suggest to the parents to really engage with your experts and to follow their advice is what I would suggest.
Dr. Kakar, do you have anything to add on as
No.
physician?
Yeah, no, it's exactly what Rob is saying. And it's difficult because there's some cases where it's really clear and we have that clinical trial data, which for us is sort of that gold standard to say, listen, the medicine in this case is going to have a benefit for your child. We really do recommend it. And then there's other cases where a child is completely asymptomatic after all the tests that we've done. And there's really no trial data to say that the medicine's going to have benefits, but there is some data to suggest that there may be side effects from the medication. So at extremes, there's extremes where it's clear, there's extremes where it's not clear. And then when it's not clear and it's a gray zone, for example, the child might have one symptom or slight symptoms, that's when we really put the big picture together. Sometimes we have group doctor meetings together to come up with a consensus that we'll present to the parents. So it's really important we have this discussion, and that in some instances it's going to be absolutely clear we treat or we don't treat, and in some instances where it's gray, we're going to put everything together to see for that individual child, is this medication likely to have more of a benefit or present more of a risk?
Hey, Dr. Kakar, in your experience, do the parents, are they more like Rob Tatros where they just kind of follow your guidance and they have full faith, or do you see kind of all sorts of different?
No, I think the vast majority are like you, Rob. They really want us to give them our scientific opinion, and that's where I think we do have a responsibility as doctors to make that decision and to present it. And of course, if parents have different opinions and suggestions, we're always open for discussion. But they want us to really look at that data for them. And sometimes I tell them, I'm not sure. I'm going to talk to my colleagues, and we're going to present to you our group consensus because it's a not clear area. And in talking to them years later, they all come back and say, listen, we trust you. We want you to make that decision because it's a lot. It's a huge burden to place on parents to read through that data and try to make that decision. So I feel it's our responsibility to do that work and then to have that discussion with you.
And then wouldn't you say, sorry, I'm not trying to hijack this scale up, but wouldn't you say that this goes to show the importance of one, relevant research on this so that you are able to make the most educated decision and the most educated recommendation possible? So the most amount of research, the most amount of data, the most amount of trials, and that we need funding for that. We need dollars. So if you're out there and the Canadian government needs to fund more of this, the US government needs to fund more research, and obviously we as the Canadian CMV Foundation need to do what we can as well. So the dollars that we're raising go towards helping this. So this is I think it's a critical piece of treatment and advice, but also of long-term eradication, is to get the proper research.
Oh, 100%. I can only say it because I come from the field of HIV, which is, let's say, 20 to 30 years ahead of where CMV is right now. And that right now with CMV, we're missing some basic data as to, how to predict a child's prognosis, which asymptomatic children are going to do well or not do well, who would benefit more from treatment. There are so many unanswered basic questions that it's really an underfunded, underdeveloped field that affects so many people.
Excellent. And kind of as a follow-up to this question, someone asks, is there any data to support continuing valganciclovir, which is the standard of care in terms of antivirals, beyond 6 months for symptomatic CMV babies?
I'll start with that. That is such a great question because there's parents always ask me at the six month mark, well, why are we stopping now? And sort of we say it's based on the clinical trial data and sort of the development of the child's immune system. But to be honest, there's no clear answer and there's no clear data yet because there just hasn't been a clinical trial to extend it to 12 months. In practice, some people have done it. Some centers in Israel have extended treatment to 12 months with close follow-up and close monitoring, but there's no clear trial data to suggest that there's a benefit. On a case-by-case basis, for example, if we did start the treatment late at 2 or 3 months because the diagnosis was made late, we will extend the treatment to complete a full 6 months. But right now, the only data that we have is really up to the 6 month mark.
And I guess the balance there is the trade-off is like the the side effects, right? I imagine, because if you knew for sure that it was positive and there were no side effects, or even if you thought it was maybe positive and there were no side effects, you would just treat, right? But the idea is that it comes with side effects the longer you treat, right?
Exactly. And we really don't have good data on long-term side effects after 6 months, after 12 months of treatment. We know that there are immediate side effects in the blood and the liver that we have to monitor very closely. And then there's the risk of long-term side effects from animal models and animal studies with the longer that we treat. So there's more of a potential risk than there is evidence of a clear benefit right now.
But you have seen, even Canadians, anecdotally, I know that there are some babies that have been treated for longer than 6 months in Canada.
Yeah, on a case by case. And again, I have this discussion with parents, but for example, sometimes we measure the amount of virus and the virus hasn't gone to zero in the blood, or we have a specific instance where we think based on the child's profile that they would benefit. So on a case by case basis, some of us have, but it's not something we do lightly, and it really requires discussion and a good rationale for it.
Which is so cool about like the level of involvement that you guys, like I consider myself so lucky that I had such a team that was so dedicated to the treatment plan for my son. And, you know, I think that I think it's great that parents have dedicated healthcare practitioners in Canada.
Thanks, Rob. And honestly, a plug for Canada is that we're close. We're a small country. We're a close-knit group of docs, and we also all talk amongst each other all the time. So when one's not sure, we're really a small network of congenital infectious diseases doctors who sort of all try to be as avant-garde as we can when it comes to treatment and management.
We're very fortunate to have you all here. Okay, wonderful. Next question, and I'll throw this over to you, Dr. Serber. Is there a vaccine currently for CMV?
There is not. Currently, there's not a vaccine available to treat CMV. I will tell you, however, that there are vaccines in development to treat CMV. And we can talk about this a little bit later, but there are different phases and stages that drugs go through to be approved. But one of the vaccines is in the later stages in phase 3 development right now. So there is something on the horizon. And there are clinical trials happening within Canada as well as the US for women regarding CMV.
Excellent. And we have a bit of a follow-up question here from someone who's watching at home. Hi to Riley. She says, speaking of prevention, who do you anticipate will qualify or be targeted for vaccination once these vaccines do become available?
The $1 million question.
Yeah, clearly the biggest bang for your buck would be women of childbearing potential, right? So this would be an early woman vaccine. And hopefully reduce the incidence of congenital CMV.
Excellent.
But I was going to ask Dr. Serber about the, I don't know if it's an ethical dilemma, or I'm not sure if I'm phrasing it right, but I remember at the last conference, we were talking about the concept that vaccines typically must be proven to have a benefit in the individual who's being vaccinated, whereby when we're vaccinating women of childbearing age, the benefit is not really for them. The benefit is for their future children. So is that going to be a potential problem in the vaccination space, do you think?
I don't foresee that as a problem at all, because the child's an extension of mom, right? So they do receive benefit from the vaccine down the road. So I don't foresee that as a problem at all.
Are there other vaccines in a similar situation where it's not the mom or it's actually the baby, that like another congenital type of vaccine? Does that exist?
Pertussis, so whooping cough. We do give boosters to pregnant women. We actually recommend it during pregnancy to specifically protect the newborn. So the booster shot is not really for mom, it's really for baby. Even with COVID, yes, the vaccine prevents the pregnant woman, but it also protects the infant until about 6 months of age. So we did grapple with this question quite a bit during COVID as well, and the ethics of vaccinating children, for example, who might not be so sick, but will protect others. And it was really felt that that there is precedent for this with other infections.
Because I remember this was like problematic at the prior conferences, where there was a sentiment that we wouldn't be able to get around this question of, and at the end that we would have to like phrase it or word it that, well, you know what, preventing moms from getting positive CMV infections is still a good thing, because it's still, you know, a cough or whatever, a cold, or, you know, they're still going to spread that, similar to COVID, I guess, right?
Yeah, and you know, even for children, there's talk of vaccinating children for CMV in order to reduce their transmission to their parents, their moms. So there's a lot of discussion and a lot of ethics, sort of a lot of thought about the ethics. I think the nice thing is COVID has really changed our framework for these discussions and accelerated the ethics lens with which we look at these discussions. So I think once we're ready to go with the CMV vaccine, we've got the framework to be able to really dig into this. But I'm confident that either children or pregnant women, it would be acceptable. It's just getting that message out there appropriately.
And right now, the phase 3 vaccines that are happening are all targeting the women of childbearing age, right?
Correct.
Excellent. It's very exciting progress being made. Next question here. How common are reactivation and reinfection? So specifically with pregnant women.
And maybe what is that?
Yeah, that's a good place to start.
Okay, I can start. And so this is really important because it's a misconception that if you had CMV and you sort of what you call antibody positive, you're protected for life, which isn't the case, because what happens is there are so many strains of CMV. So you can be infected with a new strain of CMV. So that's called a reinfection, or your own CMV can wake up. So if your immune system is down for whatever reason, medication, another condition, your own CMV can wake up. And that causes what we call active viremia. So an active state of CMV through which you're more likely to transmit the virus. So there used to be a thinking that the type of infection you can transmit from your own virus waking up, reactivation, or the virus getting a new strain was less severe. But now we're actually realizing that it's very similar to how it is when you get the virus for the first time. So they're very common. We don't have a good estimation, and there's a lot of studies, and our team in Montreal is working on this as well, to try and pinpoint how many times a pregnant woman might be reinfected, or is she just reactivating and transmitting. So we don't have clear numbers on that, but we do know it's very common because CMV is so common.
Is it kind of like COVID?
So that's a great question. And I think now that people know so much about COVID, people's understanding of virology is incredible these days. So in a way, the difference is that COVID doesn't become what we call a chronic infection. It doesn't stay latent in your system. So CMV, on the other hand, it does integrate, and so it does stay latent into your system. So there is a slight difference, but when it comes to strains and your risk of reinfection after having been exposed to COVID or having had COVID once already, that principle is similar. The big difference is that once you're infected with CMV, you do not get rid of the CMV in your body. You do not eradicate the virus from your system.
I remember when I went to the conference in Atlanta in 2008, I think it was the Public Health and Policy Conference in Atlanta in 2008 on CMV. I looked at my notes recently, I still have them, and there was like a book, and in it I wrote in big letters, I just wrote, just need to get women infected, right? I wrote on that, like, that's the solution. And we just need to screen women at birth, or we need to screen women before they start giving birth to see if they're CMV positive. I remember this was a very, very common thought back in the day, right?
Wow.
And then we obviously, I mean, I didn't make that up. I heard someone say it. Sure.
Wow.
But it's crazy that's what we were thinking 14 years ago.
Wow.
So much has changed.
That's incredible. But yeah, you nailed it. That's what we were taught in med school. You know, that's how I was taught coming through. And now it's completely different to say, no, listen, you're just as risk you have just as much as risk if you're CMV positive as if you're CMV negative.
That's really good to know, and really drives home, again, the importance of these prevention strategies, washing your hands, things that we're all kind of used to doing now during COVID. Hopefully people will continue to reduce their risk. This is an interesting one. So should we be screening women when they are pregnant and or trying to conceive? I think that kind of answers the question a bit, at least in terms of trying to conceive. Is there any evidence for prenatal screening, for screening pregnant women for congenital CMV?
I mean, I can start. There's been a lot of debate with this for a few reasons. The one we just discussed, and that having a positive status does not guarantee you protection. So we don't want to give a false protection to people. The second thing is the challenge in interpreting some of those results, because the serology results are difficult to interpret, and it's not always easy to pinpoint the timing of infection. And in many instances, some parents have major decisions to make if they believe their child is infected with CMV. And it causes a lot of stress and a lot of anxiety. And in some situations, that stress and anxiety isn't warranted. So there's been a lot of debate in the obstetrics community about how to do this correctly. And I think what we're thinking is, if you're in a system where you have access to excellent testing, and that includes more precise measurements of avidity, for example, how long you've been infected, and you have access to clinical care and teams and people who can help you make this decision, then definitely screening in early pregnancy or preconception with guidance for follow-up is really useful. And some places like Israel are doing that because they have that expertise, they have the system set up, so it's built into their screening program. But if you're in a place where someone does a test result and there's no one around necessarily to clearly interpret that and to guide the parents and to bring them into care, it's not a good idea until you have the system set up for it.
So we're coming up on time here. I just want to throw one more last question out here. Someone asks, as a parent, where can I go for help or resources in my community? So as a parent who's just received the diagnosis, what are some resources? What are some places they can go for help? Rob, I don't know.
I'll start. Yeah, I'll start. I'll be quick.
Yeah.
So go to www.cmvcanada.com. Go to our website. We are a parent advocacy group. We are a parent support group. So we are there for you. We can connect you with a mentor. We can connect you with another family that's gone through something similar. We can connect you with the right resources if you feel you're not getting the proper support in your community for whatever reason. Maybe you're in a rural community and maybe there's less information. We can help with that. We are connected with quite a few healthcare practitioners that take CMV to heart. So if you're getting the positive diagnosis and you feel you're not getting the proper treatment, feel free to reach out to us. We can help with that. If you're a CMV positive parent and you're going through treatment and you want support, you want to talk to other families, reach out to us. If you're a CMV parent and you want to advocate, maybe after treatment or something like that, reach out to us. We are here. We have resources, and we'd love to hear about your story.
Great. Thank you, Rob. So I want to say a huge thank you to all three of you, to Rob, to Dr. Kakar, to Dr. Joe Serber for joining us today, for answering these questions. Again, like Rob said, if you're a parent out there and you're looking for more information, please visit cmvcanada.com, reach out to us, info@cmvcanada.com. We would love to connect with you. A big thank you again to Centricity Research for supporting this activity and our activities all month. Like Dr. Serber said, there are clinical trials starting for a CMV vaccine across Canada. We have more information on our website, so if you're interested in getting involved in those, you can go to cmvcanada.com or centricityresearch.com. While we're here, I also just want to send out a really quick reminder about the CMV Public Health and Policy Conference, which is taking place for the first time ever in Canada in Ottawa this August 21st to the 23rd. We want to get as many families from across Canada there as possible. We have scholarships available, funding to help cover the cost of travel and accommodations. So if you're a parent and you enjoyed this activity, if you want to learn more about CMV, meet other amazing families, go to our website. We have all the information about registration and how to apply for those scholarships.
You need to come to that. If you're a Canadian parent and you're watching this, you need to come to that. I went to my first one in 2008. It literally changed my life. And I got to learn so much more about the condition. I got to meet parents. I got to learn about advocacy. It put my mind at ease with respect to my treatment and what we were going through as parents. I knew that there were other people that were going through stuff. Plus, it's in Ottawa. Ottawa's a fun town. It's a great town. You're going to have a good time. I'll buy you your first drink if you come, okay? You got to come join us in Ottawa.
I will be there.
All right. Bye,
Awesome.
Ewan.
There you go. You heard it from Rob. First Drink is on CMV Canada. Hope to see you all out there. Thank you again to all three of you for participating, and thank you to everyone at home who watched. And happy CMV Awareness Month.
Bye, everyone.
Thank you.